Morning, everyone. It's Dr. Eric, your fitness physician and peptide doc. Hope everyone is having a great day. I'm going to do a very short video on testosterone lab testing and hormonal lab testing. I'm not going to cover all the nuances of all the different labs that we can do, but I will cover some of the basics. In previous videos and discussions, we've talked about some of the symptoms of hormonal imbalance, especially low testosterone in men and women. I'm going to go through some. People always ask, we talk about symptoms, which I've talked about, and I will do another video on. But it says people always ask, what lab should I get and how do I read them? Well, again, you need to make sure you see a qualified physician to interpret them for sure, because there are many nuances, many dominoes. One thing affects many others. It's not a simple protocol where it's just a number here and you have to get this number here, like your testosterone has for this, cortisol that, and this is what you do. It's just way more complicated than that. I'm not just saying that because I am a physician, because I know the nuance of it, and I've seen many errors and mistakes and unfortunately bad things happen to patients by being managed by non-physicians or people who just don't know what the heck they're doing, trying to play with their bodies and their hormonal milieu without really understanding the nuances of biology and physiology and really talking to the patient. So that's just another caveat. So a ton of labs that we can do. This is just some of them. And again, it all depends on the patient, how complicated their case is, their medical history, their background, their symptoms. But some of the basics that we will do are on the screen here. We always start with the CBC, prolactin, cortisol, LH, FSH, total and free testosterone, estradiol, DHT, PSA, thyroid panel, which is free T3, free T4, and TSH, DHEAS, which is the sulfated form. Insulin is always good to get, a Chem12, and many, many others. Again, I'll go through more detail on these on future slides and other videos. I just want to give you a quick rundown of a basic screening panel to get or to ask your physician to run. So in terms of testosterone, basically it's a little bit nuanced, but the bottom line is everyone knows that there's a total and a free component. Roughly 2/3 of it is bound to serum hormone binding globulin, or SHBG, and 1/3 of it is bound to albumin. So only about 3% or so circulates as free testosterone. The old thinking was that only the free testosterone is what actually exerts its effect on the cells, but we're finding out that some of these androgen receptor complexes can actually bind other portions of it, and some of the total is actually active as well. Here's a graphical representation kind of showing this. Again, about 60% is SHBG bound, which is important. We'll talk about that later, because basically what we're finding is that as the steroid interacts with the receptor, we're finding out that this basically the steroid, or the androgen, testosterone, and SHBG complex has its own binding site on cells and can activate cyclic AMP and other intracellular processes, and can exert its own beneficial effects on the cells throughout the body. This is also how testosterone and estradiol work, and the other hormones as well. They're shuttled intracellular to activate hormone and transcription of proteins. But again, this is important because we're finding out again that this is important as well. So roughly, again, as I talked about before, I use symptoms as the guide. Is really what tells me what's working, what's not. Labs, there's so much variability, and we'll talk about this, but basically I use them as a guide. One gentleman might feel great at testosterone level 400, another might feel like total crap. So it's more important to treat the patient, not the numbers. But in general, total testosterone range is anywhere from 270 to 280 all the way up to 1,000. Free testosterone anywhere between 30 and 150. Optimal men seems to be right around 30 to 40, 30 to 50, somewhere in that range for the free testosterone. Women usually around 3 to 4. Some women are 4 to 5. So liquid chromatography and mass spec is the gold standard, and free testosterone is often determined by equilibrium dialysis, which is the best method just for that. So some labs will just calculate it out, but these are just the rough ranges that we're looking at. Just a conversion on because some labs will report in picograms per milliliter, others in nanograms. So there's just a simple conversion chart to look at here. A lot of these, there's definitely some genetic variability. The sensitivity of the androgen receptor is diminished with what's called a longer CAG repeat. CAG, basically in our genetic code, the DNA, there's little molecules, the purines, etc., the C, and these CAG repeats with the other letters of the DNA alphabet, so to speak, can be repeated. And basically, as I mentioned earlier, the transcription and reading of the DNA conversion by translation into RNA, and from RNA into creation of protein molecules is how these things work. So what we're finding is that the higher or the more of these little repeat letters on the DNA strand that the proteins, or the ribosomes, etc., are reading, the lower the transcriptional activity and vice versa. So this affects response to testosterone as well as side effects. And this has massive potential importance to levels, LH levels, testosterone levels, diagnosis, and certainly for treatment responses. So, and unfortunately, there's no way to know this, but this is, again, where the clinical acumen comes in, where you're finding a patient having a less response or more side effects. It very well could be because of these transcriptional or these genetic variability. Again, if they have a longer CAG, they're going to have less activity. So we're also finding that the activity of these steroid hormones is also affected by what's called co-activators and co-repressors, as well as kinase signaling cascades. These are non-genetic related or non-genomic. So co-activators are other molecules or enzymes, proteins inside the cell that help activate the protein, and the entire cascade of hormonal events that is occurring. Co-repressors, of course, shut that down. And we're really getting into discovering what these are and how they work. Kinases are just other proteins that activate or turn on proteins, and sometimes can turn them off. But basically, there's a lot of other things other than just having a testosterone level high or low and SHBG high or low. There's many more factors to this. Again, this is a little bit more complicated and nuanced, and we're still learning more and more about this every day. This is just a graphical representation showing how the binding of the molecules, how it's shuttled intracellular, and the receptor activates. It goes into the cell, and then you can see these little co-activators, co-repressors, and then there's actual gene activation and translation. Very cool stuff. A little geeky, I know, but it's kind of fun. SHBG, the glycoprotein, is a glycoprotein produced mainly in the liver, but in other parts of the body as well. It's a master regulator of sex hormones. A good friend of mine who unfortunately has passed us last year, Dr. John Chrysler, is a great age management physician. He really harped big time on SHBG and really looked at this intensely and with every reason, because it is important. It is the master regulator. It's a transporter of hormones to tissues throughout the body, which prevents them from breaking down. It binds testosterone, estrogen, and DHT. And we'll get into this more later, but low levels are actually associated with elevated cholesterol levels, triglycerides, coronary disease, metabolic syndrome, diabetes, and insulin resistance. So it's better and more beneficial to have a high level of SHBG. Bro Science and a lot of blogs online will talk about all the time about lowering your SHBG, take this, take that, but you really don't want to do that. And again, it's genetically determined. You can't play around with this, but looking at overall health, it's better to maintain high. You can dose and do other things to compensate for this, but again, as we're finding out, the SHBG is important, has its own effects on the body. So in general, we're finding that we want these levels it's better to have them high than low. So again, it can be a surrogate marker for insulin resistance, and again, it's inversely correlated with all these comorbidities that I have listed here. Roughly in men, it's going to run around 10 to 60 nanomoles per liter, and women roughly 18 to 144 or so. So you can have an elevated SHBG from many reasons: liver disease, hyperthyroidism, anorexia, taking birth control pills, hypogonadism, pregnancy, low insulin levels, and many medications. And low SHBG, most commonly we see it with women who have PCOS or insulin resistance or diabetes and metabolic syndrome, but can also be seen in hypothyroidism, anabolic use or steroid use, or prescription steroid use, and high insulin levels. So a lot of women with PCOS, this is one of the treatments. We'll get their insulin level down by putting them on estradiol, metformin, and other medications. This will massively help their PCOS and insulin resistance. So again, SHBG receptors are on other tissues and organs and may function as its own hormone. So again, its own function and role as we're finding out. Some other quick slides on labs. Prolactin, always good to get a screening prolactin level because this can affect testosterone levels and could be an indicator of another condition that needs further evaluation. You want it to be just right, that Goldilocks area, roughly between 3 and 20. You don't want it too high or too low because, again, it can affect LH receptors and testosterone levels. LH and FSH, more commonly we run these in women all the time to assess their hormonal status, but also in men, LH is important. But the problem is it only sticks around the blood for minutes. It's very transient, so you have to be careful how you interpret it. It may be low on one reading and high on another, so it's more something you have to pick up and follow over time. FSH is a little bit more stable, but again, we commonly follow this more in women and men if they're looking at their fertility status. CBC, again, many nuances of this we'll get into in future videos, but roughly you want to keep the hemoglobin roughly 18 or less, 54 hematocrit or lower. There's no need to go and transfuse blood if your levels are getting up there. If you're dosing properly, you're treating your men appropriately. I've never had to phlebotomize a man, and people worry about this all the time. My friend and one of my mentors, Neil Rouzier, ties several good discussions about this on YouTube about erythrocytosis and some of the nuances of it. But basically, just a good screening test. You can also look at iron indices, different values to see if there's any anemias, any signs of underlying nutritional deficiency. You can look at the size of the red blood cells. That'll give you a clue if there's a deficiency in certain vitamins. And then we also look at the differential too, with the MEB portion, which can indicate neuroinflammation. I'll talk about that on future videos too, so stay tuned, folks. More cool stuff coming. Estradiol, 10 to 55 picograms per milliliter, can run 50 to 70 on testosterone therapy. Again, a whole nother conversation, rabbit hole, and we'll talk about this, as have my colleagues like Dr. Neil Rouzier and others. No need to lower estrogen. If men are asymptomatic, let it ride. We're finding a lot of the beneficial effects of testosterone actually come from the estradiol. Lowering estradiol can actually be harmful to the body. And we'll talk about that in the future. DHEA, roughly 250 to 500, and 500 for men, 200 to 300 for women is optimal. Many beneficial effects of DHEA on the body in terms of anabolism, insulin sensitivity, fat burning, bone structure, overall health, insulin sensitivity, and much, much more. DHT, it's about 10 to 15% of total testosterone, runs 30 to 85 nanograms per deciliter roughly, but it can run up to 100 to 500, as high as 500 on testosterone, especially if you're on topical forms. And again, this is actually very beneficial. It's way more potent than testosterone, very more androgenic, and we find a lot of the men will actually, a lot of their benefits, and especially in terms of libido and muscle, etc., is coming from the DHT. So no need to, again, to lower this. People worry about the prostate and the hair, but this is mostly genetically determined and not actually, and then the serum levels are not indicative of what's actually in the tissues. So there's no need to be lowering DHT for fears or concerns about prostate issues, hair issues, and things like this. And another thing is that, again, with labs, there's a ton of variability from not only from patient to patient, but from lab to lab. There's diurnal and circadian variation, genetic variabilities, as I mentioned, the CAG repeats and others. So, again, the labs have to be taken with a grain of salt, and again, treat the patient, look at the symptoms. A given testosterone level, like I said, in one individual may be low or normal, whereas maybe high or low in another. A given level also may be associated with adverse events or side effects in another individual and not another. And again, this probably has a lot to do with those CAG repeats. The dose response curves for each domain of testosterone action are individual, and they could be linear, log linear, or absent, meaning you'll see with slight increases of the levels, you see a gradual improvement, like with muscle strength or with other symptoms or with other benefits, like on the skin, libido, etc. Or they may be linear or log linear. In other words, they'll go up rapidly. The strength, for example, will increase from a certain level slightly. Once you hit a threshold, it'll massively shoot up further. So again, we'll talk about this on future videos, but again, there's different dose response curves for different effects, whether it's on libido, it's on mental aspect, the motivation, muscle strength, fat loss, etc. And again, this is the art of medicine where you have to tweak things just right. Again, we talked about the coactivators and co-repressors, which can modulate the translational activity of the androgen receptor. And we talked about DHT, how that complex has 10 times the activity of testosterone. And lastly, as I briefly touched on, estrogen and estradiol mediate many of the effects of testosterone, especially libido and fat loss. So again, we have to be careful with how you interpret these and what you do with them. So hopefully you like that. Message me with questions and let me know if you want to hear more. Happy to answer any questions. And everyone, have a great day.